one of the things that's really challenging with these BRAF inhibitors plus MEK inhibitors is that there's a huge scope of potential toxicity, and they're not all going to happen. So I think that there's a real need to educate patients that they need to work with us so that when a toxicity develops, we can help address it. We can help think of strategies, whether it be medication strategies or whether it be other types of strategies to make them feel better.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Rowena Schwartz, Professor of Pharmacy Practice at the James L. Winkle College of Pharmacy at the University of Cincinnati in Ohio, about BRAF inhibitor drug classes. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome again, Mo. Thanks so much for joining us today.
Thanks, Jamie. I always love to come and talk about drugs.
Well, to start off today's episode, let's start with an overview. Talk to us a little bit about the history of the BRAF inhibitors in the field of oncology.
It's very interesting how BRAF inhibitors, as well as other targeted therapies, have actually evolved. We know that cancer cells accumulate genetic alterations. And in the 70s and 80s, there was a lot of work done to try to identify those molecular alterations that were drivers of cancer cells. And because of the technology available and the work that was done with the Cancer Genome Atlas program, thousands of cancers were looked at, and BRAF was identified as one of those driver mutations. So BRAF is a gene found on chromosome 7 that encodes for a protein that's also called BRAF. And this protein is really important in cell growth and signaling and promoting cells division, as well as some other functions. When you have a mutation in BRAF, this causes that gene to turn on the protein and to keep it on. That means there's a continual signaling to the cell to keep dividing, and there's no instruction to stop dividing. Now, there's a lot of types of BRAF mutations. The type that's most common and the type that we have drugs for is BRAF V600E mutation. By signaling BRAF, we signal a whole pathway that really stimulates the cell to grow. The one thing I do want to mention before we go on is that the RAF proteins is actually a family of RAF proteins in mammals, and that's ARAF, BRAF, CRAF. And we'll talk about those a little bit later. That's becoming more important. But BRAF seems to be the one that's most predominant in some of the cancers that we use BRAF inhibitors, such as melanoma and thyroid cancers. When you think of BRAF being turned on, a BRAF inhibitor is a small molecule usually that will actually just turn off that BRAF gene and protein so that you don't get that unregulated growth of that cancer cell.
Wonderful. So when we're talking about those BRAF inhibitors, can you talk a little bit more in depth about the precise mechanism of action?
So it's usually that these mutations in the BRAF oncogene that results in the MAP kinase pathway. Now, this is really important in the whole discussion of BRAF, because when you think of MAP kinase pathway, there are things that probably everybody has heard about. It's just thinking of them all together. So it's a stimulation of tyrosine kinase of the receptor called RTK, receptor tyrosine kinase. EGFR, you stimulate it. That causes a stimulation of in RAS, which stimulates RAF, RAF, which stimulates MEK, which stimulates ERK. So you can see it's this pathway. So by interfering with BRAF, you're going to interfere with that one part of that pathway. That's really important to know, because one of the things that can happen when you block that part of the pathway, there are mechanisms that the cell can get around that blockade through other parts of the pathway.
That's important to know. And like all of those little different steps in that cascade, it's a signaling pathway. And I'm sure many of our listeners, they're hearing all those little acronyms. They're like, wait a minute, there's other drug classes that work with those ones. And so it is starting to kind of put that puzzle together of how there's different places along that whole signaling pathway that we are now developing drugs to help kind of intercept or at least become involved in a way that is therapeutic. And so it is interesting to have this conversation today and just understand it's just one piece of that pathway, of that signaling pathway, but knowing that it's much broader than that I'm sure we'll talk about in other episodes. So when we talk about the BRAF inhibitors, we're often prescribed in combination with a MEK inhibitor, MEK, which is another anti-cancer drug class. Can you explain why those two are used in combination?
MEK inhibitors, MEK is downstream from the BRAF in that MAP kinase pathway. So it is one of the strategies that can be used alone in patients that have certain BRAF mutated cancers. The data with these drugs used alone show that the efficacy is a little bit limited. And so one of the ways that has been used to try to increase efficacy is to use a BRAF inhibitor with a MEK inhibitor. The combinations have shown in certain cancer, and melanoma is a great example, that there's better overall response rates. There's more durable response rates, less chance of resistance developing at least as soon. And some of the side effects are decreased. And so I think that's a kind of important thing to bring up here. In patients that have BRAF wild type, meaning that's not mutated, if you give a BRAF inhibitor, there is a chance that you have this paradoxical activation of the pathway. And so when you give MEK inhibitors with BRAF inhibitors, it helps block that paradoxical increase in the pathway. So one of the things that we'll talk about when we talk about side effects with BRAF inhibitors is an increase in certain types of cancer. And the one that's classic is the cutaneous squamous cell carcinoma. And that's actually decreased when you use them in combination with MEK inhibitors. So you can see there's a lot of different reasons why we now almost routinely do BRAF MEK inhibitors together. Don't have to do them together, but that's why they're frequently done together in many diseases.
Yeah, it just makes you realize like when you flip one switch, it might flip another one. You got to make sure all the switches are flipping in the right way. And if not, as you mentioned, like there are sometimes risks or possibilities that unexpected and unadvisable side effects might develop. And so it sounds like with the addition of the MEK inhibitors, we're kind of trying to kind of control some of those unexpected things as well.
It's really amazing, isn't it? That like these pathways that we kind of like to get taught as like a linear thing. And, you know, they're not. They're like intertwined in ways that we continue to understand.
So what are some of the primary subclasses of BRAF inhibitors? And maybe you can highlight a couple of examples of some of the newer agents.
So when I think of BRAF inhibitors, I tend to put them together, but there's ways that we can separate them out. One of the first BRAF inhibitors, I can't say is a multi-targeted tyrosine kinase inhibitor that targeted BRAF, but it also targeted VEGF, FLT3, and other pathways. And so it really wasn't used. It wasn't very effective when it was used for BRAF mutated cancers. So the agents that we tend to think about are the specific BRAF inhibitors. And these are things like vemurafenib, dabrafenib, and corafenib. These are like your specific agents that are used often in combination with your MEK inhibitor. There is one new class that I think is worthwhile bringing up, even though it just was approved in May of this year. And that is, and this is the way that I always like to describe it because it helps understand where we use it. It's an oral CNS penetrating. So it gets into the CNS, highly selective type 2 pan-RAF kinase inhibitor, meaning it's not just BRAF, but it's those other RAFs like CRAF that we talked about. Now, this is developed and is now available for the treatment of progressive pediatric low-grade gliomas that have BRAF mutations. This is like, I would say, another generation of BRAF inhibitors that we're starting to see.
That's amazing. So what are some of the common toxicities and adverse events that we normally see associated with the BRAF inhibitors, whether unique to individual agents or just as the subclass?
It's funny because when I think of BRAF inhibitors, like when I work in clinic, I work in a head and neck cancer clinic, and we have thyroid cancer patients that have BRAF mutations that go on these agents. And there's always like this little punch in my gut when I have to go in and do education about these agents, because these drugs are associated with toxicity. And I really think it is challenging to help patients be able to go through the treatment. And so I respect the knowledge I've learned from my colleagues in melanoma to teach some of the tricks to take care of some of these side effects. So the ones that I think most people think of are the ones that patients complain of initially. And those are things like pyrexia, fatigue, those kind of muscle aches, those things. There is definitely rash. And as I mentioned, there are those secondary skin cancers, which are significantly less with the combination with MEK inhibitors. GI toxicities are not uncommon. Different patients, different tolerance in terms of nausea, taste changes. I think taste changes are one of the ones that are really challenging. You can have some ocular toxicity. It's very rare, uveitis, but it's important. That's one of the things to counsel patients about. There's some hepatotoxicity. And then the one that I think I worry about a lot is just to make sure that we do baseline evaluation. There is some damage to the heart in terms of damage to the muscle. So we look at ejection fraction, and there's also some QTc prolongation with these agents.
So a little bit of everything, it sounds like. But as you said, there's important things to emphasize with our patients as providing them that education, both in what to expect in the short term and also what are things that are maybe rare, more long-term concerns, but still important to emphasize what's needed to monitor for those complications to arise at any point during their therapy. What are some of the pharmacologic strategies that are used pretty routinely to help prevent or even manage these toxicities?
Well, the pyrexia, I think that's really concerning to patients. They feel horrible. Warning patients about this, patients with melanoma that have a BRAF mutation that goes on these agents, you can see this sometimes up to half the patients. It usually starts a couple weeks in. Antipyretics are used and scheduled, making sure they drink a lot of fluid because of the fevers and losing fluids, making sure that they call if it happens. So if we need to hold dose or do dose modification. And in some cases, we even use steroids to decrease the symptoms of pyrexia. I think that's one of the ones. In terms of how we handle other things, such as nausea and vomiting, it really is finding something that we can give a patient every day if that's going to be a chronic toxicity. And so we're so used and we're so comfortable in oncology giving antiemetics aggressively for these every 3-week chemotherapy. This is different. These patients are going to stay on this for as long as it works. And so giving them 3 or 4 medications daily is a little bit different. So we look at things that they tolerate well. It doesn't make them too sleepy. Last thing you want to do is add full dose prochlorperazine and make them sleepy on top of feeling kind of fatigued from the drug. You might try a lower dose. You might try a lower dose of a 5-HT3 antagonist like ondansetron. So really fine tuning the treatment because it's going to be a chronic treatment. The other thing I'm going to say is that these are drugs that you really look in your package insert, within your guidelines, within your institution. When do you hold the drug? When do you do dose reduction? And doing a dose reduction doesn't mean that they have to be dose reduced forever. But taking a look at how people are tolerating their quality of life, I think is essential.
I think that's such good advice. And, as I listen to you, you said it perfectly of just how different we should be approaching our patients who are on these consistent daily therapies that they're on for as long as they work. Hopefully that's a very long time. Hopefully they continue to work. But it is different from some of the symptoms or side effects that we are managing for the more cyclical therapies that, there'll be a peak and a trough, a little bit of a, they'll have that nadir point, and then we'll know that things will ease off. That probably feels different from the patient perspective of recognizing that there'll be sort of ebbs and flows to their symptoms versus when we're on a daily continuous therapy of just the realistic information that this might start soon and it might be consistently something that you have to deal with for as long as you're on the therapy. So I think that's great advice to consider as we're counseling our patients. So Mo, what administration considerations should nurses keep in mind for patients that are taking the BRAF inhibitors?
The thing that I find with these regimens is that they're complex. They're often multiple times a day. Like you're giving a MEK inhibitor usually with a BRAF inhibitor. So one of them may be twice a day, one of them may be once a day. They're often multiple pills because the tablet size or capsule sizes are not what the dose is. And that's a benefit because it helps us titrate down on the dose. I can say it's a benefit, but if I was taking 4 or 6 tablets, I'm not sure I would be saying it was a benefit. The other thing is I think people get really confused about taking multiple pills. It's just not something we do a lot anymore, that you take 3 or 4 pills per dose of a drug. So I think those things are really important. Handling issues. Now, I know this is controversy. These are not chemotherapy. Often people will recommend these are handled like chemotherapy. And I think that's just something to be aware of. But I also think it's important that people are not so overwhelmingly afraid of like handling these drugs, because they're not chemotherapy. They're definitely anti-cancer therapies. And then how to get rid of the agents when they're done. I love that our institution has a program where they can bring them back and we can help them get rid of it, because people just don't know how to get rid of them when they're no longer taking them. And you really don't want them having it around the house. So those are some of the things I think about.
Absolutely. I think that the more consistent we are seeing patients receive oral therapeutics, those are just important things to keep in mind. From a nursing perspective, is it easier just to teach everyone the safe handling for the exact same way across all therapies, no matter what? Sure, it's easier for us. It's consistent. But to your point, we have to make sure that we are equipping our patients and their caregivers with accurate information so that they don't overreact or they don't have information that would make them panic unnecessarily or would just have them be, managing these medications in a way that perhaps isn't the right way or isn't accurate. So it is a nuance of making sure we understand what type of therapy they're receiving and then what education to pair with that to make sure that we're giving them that comprehensive education, keeping them safe, but also not leaning too far in the other direction and causing undue panic or concern if perhaps it's not warranted.
I think you're absolutely right. I really am very much an advocate for careful handling, but I also am an advocate for people not to be so afraid that they have to triple flush or double flush, like when they go to the bathroom, because this is like something they're continuing to take for as long as it's helping.
As all of our therapeutics continue to evolve, we have to be okay with helping our patients understand how they're all different. We might all call it chemo forever, but we have to know underneath that common phrase is they're all very different. And I think that will only continue. So it will be important for us to be able to share with our patients. Yes, we, commonly call all these therapies chemotherapy, but yours is a different type. And what does that mean for you? So those are important things to pay attention to and to make sure you kind of preserve that time to educate your patients and give them that information so that they can use it within their daily life. So what are some of the primary patient education points that you think we should be communicating to our patients and their caregivers about their BRAF inhibitors?
I think one of the things that's really challenging with these BRAF inhibitors plus MEK inhibitors is that there's a huge scope of potential toxicity, and they're not all going to happen. So I think that there's a real need to educate patients that they need to work with us so that when a toxicity develops, we can help address it. We can help think of strategies, whether it be medication strategies or whether it be other types of strategies to make them feel better. I think people get really used to waiting till they come to the doctor to call and to tell you, this is my problem I've had for the last month. I hate that. I really like them to communicate when they get the drugs. They're often getting it from a specialty pharmacy. So we know when they start it. We can do follow-up to see if they're having toxicity, and we can help them manage it better. Because the other thing, I've seen people just want to quit therapy when we could have helped them get through it. So I think that knowing that we're partnering with them to try to make it better is really important. The other thing that I'm going to mention, because I'll probably forget if I don't do it here, is that birth control is certainly an issue, especially when we're talking about diseases such as melanoma that can happen in individuals during their childbearing years. So making sure birth control is implemented, and then for the time after, depending upon the agent, how long it needs to be continued.
I think all those are great points. What I always remember is, this was even on intravenous therapies, but I think some patients will still have an inclination to want to minimize their symptoms because they fear a dose reduction. They fear a pause in treatment, and that will impact the efficacy of it. So I think it is important, along with pairing that communication about reporting symptoms and side effects early and often. It's also just sharing that, part of this is also figuring out what is the tolerable dose for each individual patient. And, we start with sort of the recommended dosing, but it's okay that we have to adjust and make sure that they can stay on it in a way that is tolerable to them. And so hopefully opening that conversation early, not hiding, because that sounds like they're doing it with malice intent, but just minimizing it or not being honest with the side effects, as you said, it doesn't give us the opportunity to help alleviate them, whether it's with other therapeutics or dosing changes, things like that. We can't help if we don't know. And so I always try to really emphasize that with patients of you're not complaining and it's not going to be a bad thing if we have to change your dose to make sure that it's something you can tolerate.
I think that's so right. I agree with you. I think telling people up front, this is a dose that we're starting with. We will modify it based on how you tolerate it. That it means we're personalizing the dose for you. I really like that approach because you're right. There are some people that do not ever want to modify dose. And then I have people that will modify their own dose, don't want to know it when it's happening. I think that's a really good way to address that right up front. I like that.
Well, and I think to the self-modification, I mean, again, we need to make sure that they know, there are options, there are things that we can do and let's work together on them. Don't maybe do it on your own. Let's talk real quick on the phone. And I think something else that I think is important with that is now just making sure that as those dose adjustments are made, that the documentation is reflected in the EHR, which is a recent update to the ASCO-ONS safety standards for anti-neoplastic therapy. That's something that has now been newly emphasized in that new document is just the importance of recording those dose changes in a way that are shared across, even if it's a late night call, someone was on call and they made a choice to change that dosing, it's got to get in the record somehow or else nobody else will know it happened. So something really important.
I can't even tell you. That's probably one of my key things in practice. I tell patients constantly, call me if you get a new drug or an old drug or if anybody changes your dose, because I want it in that record. Some people are really good. I am not one of those people that can remember a detail about a patient from a month before. I have to look at the record to see what I wrote.
Absolutely.
I love that. Yes.
So how do you see pharmacists and oncology nurses collaborating to help manage either the adverse events, toxicities, and patient education for our patients who are receiving BRAF inhibitors? And how can we kind of collaborate to serve as that trusted source of information?
I think one of the biggest things that is needed, especially for this type of therapy, is that there needs to be a approach developed for your baseline evaluation for the things that you need to get. So for instance, in our clinic, everybody knows I'm going to want an EKG if they haven't had one recently. Everybody knows that I'm going to want to look at an echo. I want to look at ejection fraction. And if they're the person that doesn't want to look at ejection fraction, it's me. But I know those are things that are needed. So to establish what is needed with your team so that it's done routinely, it's not a person dependent. I think that's really important. And I think utilizing this is the thing I keep thinking about when I think of BRAF inhibitors. I think about using the resources within your institution, within your community of people that this is what they do all the time. I will tell you, even before today, I pulled some of the stuff that I have from my colleague who works in the melanoma clinic to see some of the recommendations that she has used, which is what I do whenever I have a patient that's going on these agents. So know who your colleagues are that might have some experience. The other thing is, don't assume that you can modify formulation. So if there's someone who can't take oral pills and has to use a suspension, some drugs there's clear indications how to do that. Other ones there's not. So collaborating on that is a really good thing. I hear too much where people will say, just crush the pill. These are not the drugs that you want to do that with.
So important. And I think you captured it perfectly. These targeted therapies are, we might still have our clinics operationally set up in disease-specific clinics based on expertise, and I don't expect that will necessarily go away. But the therapies are being used across different teams and across different specialties. And so you absolutely said it. Know who else in your world, in your realm, has experience with a certain type of targeted therapy and reach out to them so that you can borrow and build on what has been helpful for them in your patient population. Perhaps you'll have to have something different. And I really love your idea about within your clinic, creating sort of some consistent expectations or practices based on how unique all of these new therapies are becoming. Some of them require lots of different pre-tests or monitoring and things like that. And so creating a centralized place so that people can reference that and become familiar, as our teams include medical assistants and nursing assisted personnel, LPNs, RNs, the whole range of nursing assistance is there. And we need to make sure everyone has the same information so that they can be helpful as they're caring for these patients in their clinics. So what's the future look like, Mo, with these agents? Do you expect to see BRAFs on the stage in the landscape of cancer care for time to come?
Yeah, it's funny because with this new agent that came out, I was really interested in this. This is not, pediatric low-grade glioma is not where I work, but I was fascinated because it's showing an evolution of the science. So I do believe that there will be increased development of drugs that are more specific for what we need. And I think that one of the key things with that agent is that it crosses the CNS, which is important for glioma, obviously. So I think new drugs, perhaps new dosing strategies for tolerability, I think that's going to be something we're going to see. The other thing that I think is really interesting is looking at new combinations. And the example I'm going to use is with BRAF mutations in colorectal cancer. BRAF mutations in colorectal cancer is associated with a poor prognosis. And so one of the things that has been seen is that when you use a BRAF inhibitor, that patients often do okay initially, but then they get a adaptive feedback because there's a reactivation of that whole pathway, and it's mediated often by EGFR. So now one of the strategies is to use a combination of BRAF inhibitor, MEK inhibitor, plus an EGFR inhibitor. So by understanding within a disease, I think, because this is different than what you see in melanoma, I think that there's going to be these disease-specific strategies to address these BRAF mutations in certain cancers. And I think that's really interesting. And scientifically, it's really interesting. It makes it more complex, but I think it's very interesting and hopeful for even better response with these agents.
Absolutely. Well, as we all can see, things are changing at a very rapid pace. And so just staying connected to what these new developments are, what these new approvals are, comparing them to things that we maybe are familiar with, or maybe it's a completely first-in-class thing that we have to learn from the very beginning. But that is an exciting time to see how things are changing and how they can hopefully apply to our patients in the future. Well, Mo, thank you again for another wonderful episode, a deep dive discussion on BRAF inhibitors. As we approach the end of our episode today, we like to run through our quick fire series of questions to help summarize some of the things that we've discussed. So to kick that off, how do you think healthcare professionals should evaluate their hidden or their implicit bias about working with BRAF inhibitors?
I think the key thing is that if you don't use these agents very often, and I will put myself in that category, I use them, but I don't use them like, say, oncology pharmacist that works mainly in melanoma. So, but I think what happens is that you color how you think these drugs are based on limited experience. And I think it's important to realize that these drugs have toxicities, but there are ways to help patients with those toxicities, to mitigate them or to manage them. And so not to let your one experience with a patient with a BRAF inhibitor color your whole experience, where these drugs can be very helpful in certain diseases.
What are some common misconceptions about BRAF inhibitors?
I think that one of the things, I still think people think of these as chemotherapy, and they're not. And I think that's really important. I just really think it's really important to just really embrace the fact that chemotherapy is a phenomenal way to treat cancer. But we have other strategies now that can be sometimes done together with chemotherapy, but sometimes we don't need chemotherapy because of these other strategies. And I think that's really kind of exciting.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think the understanding of why we give them with MEK inhibitors. I think people just, this is the regimen, BRAF inhibitor, MEK inhibitor. I'm not sure people always understand the rationale of why we're doing it and the difference in, say, toxicity. Some toxicities are less, those cutaneous squamous cell cancers, but that some toxicities may be more, the hypertension and things like that. So I think that understanding why the combination and when you benefit from maybe going solo.
What additional training or education do oncology nurses need to help stay current in this topic?
So this is such a niche topic that this is not something that's important in the diseases that you work with, you may find that you don't stay really up to date. So I think that realizing the resources to get information fast, and I think NIH should pay me for how many times I say go to med, because I go there all the time. It tells me what size tablets these come in. It tells me the dose modifications. It tells me the experiences in terms of toxicities. The other thing is there's a lot of indications that are not things that we talk about all the time. There are these niche indications that I would not know unless I went into the package insert. And Daily Med is a really fast way to get to it without having to be on some sort of service that you buy because it's free.
And then what are some additional resources for patients or maybe other providers who want to learn more?
There are some nice review articles now because of, I think, the interest in some of the evolution of BRAF inhibitors. So there are some nice reviews. And if you want, I can send you a couple if you wanted to post them.
That'll be great. Yeah, we'll be happy to keep those or include that link in our episode notes for today. Well, Mo, thank you again. It's always a joy to have you on, and I always learn something when we talk about this latest drug class. Today was BRAF inhibitors, but as we mentioned in the beginning, there's a whole series of different drug classes. So I encourage our listeners to review those if they want to learn more about other classes. Do you have any final comments to share with our listeners today, Mo?
No, I just want to thank you because I may think I know the drugs we're going to talk about, but I always do reading before to prepare. I always learn new things and I love it.
And you share them with us, so we all win.
Yeah. Thank you so much.
Thanks so much, Mo.
Take care.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.